Next case. Next case we have is a 59-year-old woman who comes to the emergency room with 2 days of abdominal pain and fever. And we have a person who has clear ascites from clear cirrhosis, from clear alcohol-induced liver disease. From alcohol-induced liver disease, we have ascites. We have a person who's got ascites and a fever. And ascites and a fever by itself means I need a paracentesis. Ascites and pain means I need a paracentesis. Ascites and tenderness means I need a paracentesis. But with ascites and pain and tenderness and fever, in that case, I need a paracentesis. So if this is a single best answer question, the question would be, what's the most accurate diagnostic test? It would be a paracentesis. So if I'm saying I need a paracentesis, what are all these other tests for? And these are not to make specific diagnoses. They are because these are the tests that you do around the diagnosis. In other words, I get a CBC. Well, I'd be interested in a platelet count prior to putting a needle in somebody's belly. Oh, I get a prothrombin time, because what information does the prothrombin time tell me? What's the test? Liver function. Prothrombin time is actually the most accurate of the liver function tests. It's the most accurate of the liver function tests. The prothrombin time. The albumin level and the prothrombin time are actually the two most accurate liver function tests. Because you'll notice that the transaminases are normal. And the day that you die of your liver disease, you die with normal transaminases. The day that you die of your liver disease, you die with normal transaminases because there's no liver left. The liver is like a grapefruit that you're juicing and juicing and juicing. And the transaminases are the juice. And the day you die of your cirrhosis, your liver has been juiced out, and there's no transaminases left in it. It's all been juiced out. And that's why the transaminases can be normal on the day you die of liver disease. But prothrombin time and albumin, they truly tell me how synthetically normal my liver is. Now, although it doesn't give you the direct diagnosis here, we do have a woman who seems to have peritonitis. And although we think it's not a hole in her belly, the abdominal x-ray and the chest film are the best way to tell me if I have a hole in my belly. But I would like you to notice that you've got to have a chest x-ray to see air under the diaphragm. It is the chest x-ray when you want to really see air under the diaphragm, not the abdominal x-ray. But it is the chest x-ray when you want to be sure. You might see air under the diaphragm on the abdominal x-ray, but you might not. You always see the diaphragms on the chest x-ray. It depends who you are. It depends on bodily size. Stand up for a second. Stand up. Stand up. Trust me, sweetheart. For instance, you could do an abdominal x-ray on some people and get an abdominal film, chest film, and sinus films, all in the same x-ray. Or on me, you wouldn't see the top of the diaphragm at all. So it depends on who you are, depending on whether you'll see the tops of the diaphragms or not. Another exciting moment in medical education, huh? I felt it. So when you want to see for sure the air under the diaphragm, you get an upright chest film because you might not catch it. All these tests are to see whether there's other things around the peritonitis and to see the liver function test and to exclude perforation. And if this is CCS, you should get all these all at the same time. And if you enter them all at the same time and you hit return, they'll all be done at the same time. Single best answer, you say paracentesis. Now let's see. You do the paracentesis. Let's see if you've heard this before. You put a needle in the belly and you get out a sample of the acidic fluid. What would be the most specific diagnostic test on the acidic fluid? Culture. Even if you've never studied it, culture on the acidic fluid is the most accurate, most specific test. When do you wait for results of culture? Never. You take the culture and you give antibiotics waiting for results of culture. Gram stain is specific, but it's not very sensitive. Protein and LDH are sensitive, but they're not very specific. Have we danced this dance before? Have we done this before? Does it seem familiar? Yes, it does. Culture is the most specific, but you can't wait for results of culture. Proteins and glucoses and chemistries are not specific, but they are fairly sensitive. So the way that you tell now is cell count. CSF greater than 5 to 10 white cells is abnormal. What is it in peritoneal fluid? (250 polys or 500 total white cells would both be fine. 250 polys or 500 total white cells would both be fine. So the thing is either of those. So let's say actually just greater than 500 total white cells. But what about the joint fluid? And I tell you that you've got a red, tender, swollen, so that's 7,500, greater than 500. You've got a red, tender, swollen joint. You've got a 74-year-old Catholic nun with painful knees. 74-year-old Catholic nun with a red, swollen, tender, immobile knee. And you've got 500 white cells in that joint fluid. What does that mean? Normal. She's got osteoarthritis. It's normal. It's normal. You see, in peritoneal fluid, 1,000 white cells in peritoneal fluid is peritonitis. But in joint fluid, you'd have to have greater than 2,000 to be significantly abnormal. 2,000 to be abnormal, and 2,000 to 20,000 is probably more inflammatory. Whereas greater than 20,000 to 50,000 means infection. There's overlap. There's overlap. The same way, urine. Most accurate test is a culture. Don't wait for results of culture. You use greater than 10 white cells in your urine to tell you. Do you get the point? It's saying the same thing over and over and over again. Urine for cystitis or pyelonephritis, joint fluid, cell count, cell count, cell count, CSF, joint fluid, urine, all of them. All of them. It's just that the cell count changes depending on the area. What drugs are the best here? And don't say broad spectrum, and don't say treat. Or you get a spanking. Okay? So, the most, okay, what drugs? Well, actually, how about any of these? Yes, it's true. But for a matter of convention, the third generation cefotaxime has become standard of care in people who have spontaneous bacterial peritonitis. And we accept this, cefotaxime. It's a third generation cephalosporin. It's just like ceftriaxone. Questions on SBP? Okay. Next case. I've seen this somewhere before. Abdominal pain, mid-epigastric tenderness, pain, rebound. Guarding, rebound, guarding, rigid, rebound, guarding, rigid. I've seen this before. It's called peritonitis. Guess what they don't ask you in this case? The diagnosis. My mother could get this diagnosis. This history, this physical, they ask you what is the next best step in management. I know, you're scared of making eye contact. You're afraid I might talk to you and ask you a question. I understand. I got the picture. All right, I'll leave you alone. All right, sorry. Now you're afraid not to make eye contact. I understand. Like deer in the headlights. This history and this physical. What's the next best step? Action. What would you do now? IV fluids? IV fluids or abdominal x-ray? Or upright chest. I told you, upright chest is the one to see that thing, right? Upright chest, depending on... I don't know. Would you treat the hypotension first or would you get the x-ray first? I'd do a lot of things. What would you do? Resuscitate him. What does that mean? Domine, 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 the Pater Christ compels you. Resuscitate him. Rise. IV fluids, because the person is hypotensive. Hypotensive. The most important thing here is the hypotension. And anytime you see hypotension, the answer is easy. It's IV fluids. Except, of course, if it's an arrhythmia. But IV fluids, IV fluids. IV fluids is the most important thing right now. IV fluids. So IV fluids first. What flavor of fluids? Normal saline or Ringer's lactate? Either one, either one, either one. Just not half normal saline, not D5W, not quarter normal, not third normal, not any of that stuff. Normal saline or Ringer's, normal saline or Ringer's, and they've already given the IV fluids. They've already given the IV fluids, and now they say, what do you do next?
Check the vital signs.
Check the vital signs, okay. Now, next, is it chest x-ray, abdominal x-ray, IV antibiotics, chemistry, CBC, straight to the operating room? IV antibiotics. IV antibiotics, because there's nothing you're going to find in that chest x-ray that's going to tell me that they don't need the antibiotics. Also, we are in the infectious disease section, right? So you're going to have a very hard time telling me that someone who has peritonitis, and it's like this, rigid, board-like abdomen. You go, he's malingering. Hold the antibiotics. Antibiotics. Now, you'll notice the air fluid levels are seen on the x-ray, but you don't see the tops of the diaphragms. You have a low serum bicarb because this patient has a metabolic acidosis. Why do they have a metabolic acidosis? No, the low pH and low bicarb means they have a metabolic acidosis. That's like saying, why are they hypoxic? And you say, because they have a low O2. That's like saying, why are you poor? And you say, because I have no money. Why has this person become Hasidic? Because they're septic, hypotensive, sepsis and hypotension. Sepsis and hypotension, and they're acidotic. Why does this person have hyperkalemia? Hyperkalemia. Because of shift, because of acidosis, because of hypoperfusion, because everybody who's acidotic becomes hyperkalemic. Everybody who's acidotic becomes hyperkalemic. Because every time you have acidosis, every one of your cells is in the business of sucking up that acid so that you don't die of acidosis. And as you suck up that acid into the cells, your cells release potassium. Your cells release potassium by sucking up potassium into those cells, hydrogen into the cells. It releases potassium. And everybody who's acidotic becomes hyperkalemic. And everyone who is alkalotic becomes hypokalemic. Acidosis, alkalosis, controlling potassium, moving in and out of the cells. So everyone who's acidotic becomes hyperkalemic because there's transcellular shift of potassium out of the cells. And you have here low CO2, respiratory alkalosis. Low bicarb, metabolic acidosis. Low CO2, respiratory alkalosis, low bicarb, metabolic acidosis. How do I tell when I have two acid-base problems going on? How do I tell which one is the primary or main thing? The pH. The pH is always closer to the primary thing. I have two things going on. I have a metabolic acidosis and a respiratory alkalosis. Every time the CO2 is down, I have respiratory alkalosis. Every time the bicarb is down, I have a metabolic acidosis. How do I determine the primary disturbance is the pH? I have a high white count with a left shift. That's any cause of infection. I have metabolic acidosis and hyperkalemia, and that's any cause of sepsis. These three things, 3, 4, and 5, would be the same if it was lactate, which it is in this case, methanol, uremia, DKA. Every single one of these would have the same blood gas. Every single one of those. Every single metabolic acidosis with an increased anion gap, or actually even with a normal anion gap, every metabolic acidosis will have the same pH, the same blood gas, the same potassium, the same bicarb. They all have the same one. What would be the most accurate diagnostic method for this patient? Most accurate thing to establish a diagnosis? You open them up and we look. There you go. That's why people go into surgery. You open them up and look, right? They got a hole in them. Open them up and looking for the hole. Well, I don't know why you think so much. Got a hole in them. Open them up and look for the hole. And then the treatment? Well, fix the hole. You're not supposed to have holes in your bowels. So open them up and look for the hole, and if you find a hole, stick your finger in it. And sew it up. Yeah, it's about that deep. It's about that deep. Questions on this case? As opposed to the spontaneous bacterial peritonitis case, this is a person who's got a hole in the belly. And the upright chest shows the air under the diaphragm, as we talked about. Now, this is what a Swan-Ganz looks like in sepsis, but I didn't say that you have to put a Swan-Ganz in all these patients. I don't think it's worthwhile in a patient like this, but how do I know which case they give you? I don't know. The Swan-Ganz shows that the cardiac output is way up because you're septic and the heart is trying to work overtime to deliver more oxygen and more blood. I've got a low wedgie because your heart is trying to move overtime and deliver more blood. I've got a decreased peripheral vascular resistance because I've got endotoxins circulating in my bloodstream, dilating all of my peripheral vasculature from that E. coli gram-negative endotoxin. And then the antibiotics would be basically the same as we did before. These drugs, dopamine, neosynephrine, you mean the stuff I use for my nose? Yeah. Isn't that cool? It's an alpha agonist. It's an alpha agonist. Dopamine, neo, and norepinephrine are all drugs that are used to maintain blood pressure, but it's always fluids first if the blood pressure is low. You see how you guys love always answers. Blood pressure low, it is always fluids first. Always. You love always answers, and there's a nice always answer for you. Questions on this case? There's a lot of repetition in the infectious disease section. Next case. I want to be a lifeguard. I want to guard your life. And now he had some amoxicillin. And now he's got some otitis media. And it's getting worse. And he's bulging. And he's red. And you've got your very own bulging red Lifeguard. What are you laughing at? Just projecting. You're projecting your own perversity. Okay. How do you know that this can't be just otitis media? How do you know it can't be just otitis media? Look at the case. How do you know it can't be just otitis media? What? Yeah, no matter how bad your otitis media is, it doesn't move your ears. No matter how bad your otitis media is, it doesn't move your ears. It doesn't move your ears. Okay? No matter how bad your otitis media is, it doesn't move your ears. Okay? So that is a real problem. Okay? So therefore, there has to be something else there. What's there? Mastoid. So this is otitis media spreading into the mastoid hair cells. And the only point of this question is, what's the most accurate diagnostic test for this? To look into that bone there. To look into that bone. Quiet! The most accurate test to look into that bone. Quiet! Aspiration or CT? Huh? You don't know what to do. You're like, I want to get a CT, but he has said culture is the most accurate, but I want to get an MRI. But he said I must not get MRI, I must get culture, but I cannot. Ay, suave, papi. Ay, cálmate, mami. Расслабься, пожалуйста. Don't prolapse a hemorrhoid or anything. The most accurate diagnostic test has to be the aspiration. Now, an X-ray should be done. A CT can be done. An MRI is accurate, but no matter how accurate those radiologic tests are, they're not as accurate as a tympanocentesis. They're not as accurate as aspiration. No matter how accurate those are, they're not as accurate as an actual culture. So that's why it's the same principle here. Yes, an X-ray is a nice thing. Yes, a CT scan is a good thing. However, tympanocentesis for culture is better. Now, you ever have a soft-boiled egg? Eat a soft-boiled egg? Soft-boiled egg, right? Tap, 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 tap. Pull off the top and then treatment for mastoiditis? Pull off the bone and it's worth it just for that look of disgust in your face. That's debridement of those mastoid air cells. Debridement of those mastoid air cells. Ready? Clean out those mastoid air cells. Same idea. Same idea. Next case. Yeah. I would probably get an X-ray first in terms of management first. I would give him. I would expand out his antibiotics and get an X-ray first. It depends what's asked. Depends what's asked. You see, I can't answer some of those questions because I don't know what's being asked. You say, what do you do next? I can't make like 1, get an X-ray. 2, then get a CT. 3, then get an MRI. 4, then aspirate. 5, then give antibiotics. I don't know. Well, then we're all going to fail. No, I can't. See, this is the thing. When I say I can't give you an answer, it means you have to change the way you think. That's what that means, basically. In other words, if I tell you that you can't give me an answer to that, it's because, hold on, stud. Okay, it's because the question, it's not like it's ACLS. If this was ACLS and we had VFib management, it would be shock, then shock, then shock, then epi, then shock, then lidocaine, then shock, then procainamide, then shock. Then it'd be 1, then 2, then 3, then 4, because it's always that way. Ventricular fibrillation management is always shock, 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 epi-shock, lidocaine shock, procainamide shock, always. But you see, in this map of management, it might be different. They might tell you that the person has already had an X-ray and a CT, in which case the next thing to do might be debridement. They might tell you that the CT was non-conclusive, in which case there might be an MRI. So it depends on what the circumstances are. It might be take him to the OR. It might not be. It depends what the circumstances are. You see, this is the thing like when you came up on the break and said, I had a person with mitral valve prolapse, but they said not to give prophylaxis. Well, mitral valve prolapse is prophylaxed if it's combined with a bacteremia-causing procedure. Next case. I'm sorry, go ahead here. Huh? You might be able to treat it with IV antibiotics and not surgical debridement. That's the whole point. You might be able to treat it with just antibiotics. Yes. And that's why I'm resisting these things of always take them to the OR, always do this. Can't do that. You can't say always. It's wrong, because then the circumstances will change. Think of the question. What's better, a car or a plane? It depends. It depends on the circumstances. A 55-year-old man is brought in with deterioration in the form of memory loss, change in errors in judgment. Symptoms started 3 months ago and are progressively worse. He's getting incontinent. Can this be Alzheimer's disease? No, it can't be Alzheimer's disease. Why can't it be Alzheimer's disease? Well, first of all, he's too young. So let's change him to 75. If this guy was 75, could this be Alzheimer's disease? No, even if he's 75, this still can't be Alzheimer's disease. Why not? This is steady onset. This is progressive. This is steady. This is progressive. What? It's too quick. Even if this was a 75-year-old guy, this still can't be Alzheimer's because it's too quick. It's too rapid. It can't be Alzheimer's because 3 months ago this guy is doing your taxes. Now he can't find his way to his own bathroom. So it's too rapid. It's too rapid in onset. It's too rapid in onset for this to be Alzheimer's disease. It's too rapid in onset for this to be Alzheimer's disease. Okay? So, even if he's 75, it's still too rapid. The fact that he's under 75, under 65, under 60 makes it pretty much impossible for this to be Alzheimer's disease. Could this be normal pressure hydrocephalus? No. Why can't this be normal pressure hydrocephalus? There's no incontinence. There's no incontinence. There's no incontinence. There's no incontinence. Now, if this guy was urinating on your leg, if you had a wet leg, if you see a wet leg, then we'd have normal pressure hydrocephalus. If we had a little wet leg here. Oh, we don't have a wet leg, we don't see any incontinence, so therefore unlikely to be normal pressure hydrocephalus. Could this be a brain tumor? Huh? It could be, where's the brain tumor? Cerebellar. Oh, so that's why he's got the ataxic gait. Then how come he's got the memory loss? If it's cerebellar. Oh, it's frontal. It's frontal. He doesn't know who he is. Then how does he have the ataxia if it's frontal? It moves. Leans forward, it's frontal. Who am I? I don't know who I am. Leans backward. It moves. It's diffuse. You can't get any one anatomic lesion to cause this problem. You can't get, impossible to get, any one anatomic lesion to cause this problem. There is no one anatomic lesion to cause both memory disturbance and ataxia. There is no one anatomic lesion to cause this problem. You would have to have multiple things, multiple lesions to have this problem. So there's no one anatomic lesion to cause this problem. And to say that a guy has got a head full of metastatic disease, to say that the guy has got a head full of metastatic disease and that he's got no headache, no nausea, no vomiting, but an entire brain replaced with tumor is a tough thing to do. Too young for Alzheimer's and it's too rapid. He's lacking all lot of symptoms for metastatic disease. Plus he doesn't have a primary, of course. Normal pressure hydrocephalus, we would have to have some incontinence to recognize the case. How about neurosyphilis? Neurosyphilis, yes or no? Huh? And the answer is neurosyphilis. It could be neurosyphilis. It could be multiple neurologic deficits all over the place. Neurosyphilis. What if I tell you you had a macrocytic anemia? Could be B12. What neurologic deficits can you get with B12 deficiency? Anything. Isn't that easier than memorizing? Cleansing breaths, just like Lamaze, could be B12 deficiency. Could be B12 deficiency. An abscess. An abscess where? Where? Multiple abscesses in a guy with no headache and no fever is a very hard thing to do. It's very hard to do to say a guy's got his head replaced with something pussy in his brain. I'm sorry, it's purulent. But a head full of pussy stuff, what? Are you projecting again? I'm sorry, that's not, it'd be purulent, sorry. So a head full of purulent material. Okay. Something pussy on the brain, you can't have that with no fever and no headache. Multiple lesions. Just couldn't be. And besides that, here we go. CT, MRI, there goes a normal high pressure hydrocephalus, metastatic disease, multiple strokes, and multi-infarct dementia. Second most common cause of dementia in the United States after Alzheimer's disease is multi-infarct dementia. Yeah, that's good. That's good. Whatever the teacher says is the answer, you just go, yeah, that's it. That's good. That's how to get honors in all the rotations clinically. You go, yeah, that's it. As soon as they say the right answer, you go, I was just about to say that. I was just about to say that. So the LP shows a normal VDRL. There is no macrocytic anemia, and then this becomes rapidly progressive dementia with myoclonic jerks. Rapidly progressive dementia with myoclonic jerks. Rapidly progressive dementia with myoclonic jerks. And once you see it and you know what it is, then it will always be clear to you. It's like the lupus anticoagulant. At the beginning you go on, elevated PTT, but they're not bleeding. I don't know. Then you go, oh, elevated PTT, normal PT, no history of bleeding and a history of clotting. Must be a lupus anticoagulant. Here, rapidly progressive dementia with myoclonic jerks. Creutzfeldt-Jakob. Now, Creutzfeldt-Jakob is not a common disease, but it is a trendy disease. It's reported in everybody's favorite medical journal, which is the New York Times. Okay? So the thing is, when you see, because it's related to bovine spongiform encephalopathy, mad cow disease, angry bovine, don't eat British beef. Okay? Bovine spongiform encephalopathy, also known as variant Creutzfeldt-Jakob disease. How do you get Creutzfeldt-Jakob disease? Huh? What? Hanging out with cows. I've seen that. That's the name of my next movie. Girls riding with boys and hanging out with cows. Eating raw meat. No? Brain. Eating brains? Oh, I know what it is. You said, come on over. We're having Dad for dinner tonight. Yes? People who eat brains? Ah, brain and sausages. Yum, yum, yum. We're bringing Grandpa over for dinner. And that's the most common wrong answer. You are thinking of kudu. You are thinking of kudu. God, you just like saying kudu. Like a tribe of some kind. Yeah. Kudu, kudu, kudu. Well, listen, those guys in New Guinea are not stupid. You go over them and you say, listen, don't eat Dad's brains or you're going to get demented. And they go, okay, we're not going to do that anymore. Find another tribal ritual. All right. They're not stupid. Kuru is extinct. So that's not how you get it. Bovine spongiform encephalopathy is by beef, but it's not yet been, or just about now being described for the first time in the United States. It's not really been in the United States. You get it by transferring brain products like growth hormone, the old growth hormone that used to be pooled. Take all these pituitaries, put them in a blender, inject them into people. Okay, growth hormone, corneal transplants, dural grafts, transferring a little brain around. A little unprotected contact from the wrong brain. Kuru is an extinct disease. That's the one that you get from eating Dad's brains. And remember, kuru is not koro. I see this on a wrong answer. People go, koro. No, not koro. Kuru. What is koro? Who can tell me what koro is? Why am I not surprised that you know the answer to this, Glenn? Okay, go ahead, Glenn. Let's have it here. Glenn's going to... Koro. Let's see. Oh, my God, another extrovert.
Koro is apparently a phenomenon found principally in the Japanese peoples.
Philippines.
Who have a fear of a disappearing penis. The penis begins to retract into the abdomen, and family members actually sometimes sit up all night with a string wrapped around the penis so that they can pull it back into the exterior world and soften the blow to the patient's ego.
Wow, and I thought I had more problems in my home life. People sitting around with a string on Mr. Happy, trying to bring it back to the outside world there. But that is true. It is true. Koro is what Glenn just said. It is not kuru. Creutzfeldt-Jakob, rapidly progressive dementia with myoclonic jerks. Rapidly progressive dementia with myoclonic jerks. CTLP, no treatment. CTLP, but no treatment. All right? CTLP, no treatment. Okay? Questions on Creutzfeldt-Jakob? The etiologic agent is a piece of protein called a prion. A piece of protein called a prion. Okay? A piece of protein called a prion. It's a piece of acid. A piece of acid. Yes, it's a piece of protein part. But nobody has any idea what prions are. And a guy named Stanley Prusner recently won the Nobel Prize a couple of years ago for the identification of prions in Creutzfeldt-Jakob, and he doesn't know what they are either. And it means proteinaceous particles, and we have no idea. It's a transmissible spongiform encephalopathy because it makes your brain turn into a sponge. Why it does that, we don't know. All we know is we have no therapy for it, and it's transmissible by moving brain products around. And it's trendy. The reason I spend the time on it is because it's similar to bovine spongiform encephalopathy, and that's trendy. Let's take a break before the next case. The risks for endocarditis require the combination of both a significant cardiac defect as well as a bacteremia-causing procedure. The mere presence of a significant cardiac defect, like mitral valve prolapse with regurgitation, is insufficient to result in endocarditis, and therefore doesn't need prophylaxis. It has to be both of these things combined. So when people say, but listen, on a routine teeth cleaning when there's no bleeding, do you need prophylaxis? No. But what about if there's a VSD? No. But what about if there's an aortic valve replacement? No. Because it's not a bacteremia-causing procedure. You need both things to require the need for endocarditis prophylaxis. Let's go to the next case, shall we? Case 10, I'm here to see what medications I need. Don't we all? A 47-year-old woman found out she's HIV positive. Healthy, took the test because her boyfriend died of AIDS. Oh, okay. I only took the test. Listen, I don't need it. I just happened to have a boyfriend who died of AIDS. Oops. And now I have 47 T cells and a viral load of 180,000. 47 T cells and a viral load of 180,000. So the question is, what prophylactic medications she would need? So the first thing is, what prophylaxis would this person need? Prophylaxis. What does she need for prophylaxis? Huh? I can't hear you. PCP begins at a T cell count less than 200. Less than 200. In this case is now, since HIV changes more than other things, this case is now you're the first group in the country to get the most current thing. Things haven't changed much in terms of peritonitis or even in meningitis. But the issue of HIV, this has changed. This does change. So you're the most current one. PCP. The best initial therapy for PCP prophylaxis is trimethoprim sulfa, is Bactrim. What's the most common adverse effect of trimethoprim sulfa? Allergic reaction, a rash. And if you get a rash with trimethoprim sulfa, what should you use instead? Dapsone, yes. Dapsone is for prophylaxis, but not for active treatment. Dapsone is for prophylaxis, but not for active treatment, because there is no intravenous version of Dapsone. So Dapsone is for prophylaxis, not for active treatment. But if you have a G6PD deficiency, if you have a glucose 6-phosphate dehydrogenase deficiency, and you're going to have hemolysis, what would you use instead? Pentamidine is the wrong answer. Atovaquone is better. Pentamidine is a dog. Pentamidine is if you can't tolerate everything else. Mepron, also known as atovaquone, an antiprotozoal drug that will prevent the development of pneumocystis, has less breakthrough than aerosol pentamidine. Atovaquone is equal in efficacy to Dapsone, whereas aerosol pentamidine has more breakthrough. Aerosol pentamidine is a dog. We'll work on mild disease. What other prophylactic medication does she need? CMV, no. Toxoplasmosis, no. Mycobacterium avium complex, also known as Mycobacterium avium intracellulare, begins at a T cell count less than 50 CD4 count. And what's the best initial prophylaxis for Mycobacterium avium? Clarithromycin is almost right. It is. It's almost there. But azithromycin is better. Azithromycin is better. Clarithro is okay, but azithro is better. Azithromycin is better. Azithromycin is better. Because Clarithro, although it has equal efficacy, why should you use a dose of a drug 14 times a day when you have azithromycin that can be used once a week? What else is routine prophylaxis for everybody at this T cell count? What else should everybody get? Well, Pneumovax, last I checked, was not a prophylactic medication, but it is a pneumococcal vaccination. And Pneumovax, yes, they should get pneumococcal vaccination. What T-cell count? Any, as soon as you find it. As soon as you find it. Any CD4. Any CD4 as soon as you find it. What else should she get at this? Well, PPD. At what T-cell count should you get the PPD done? Any. It doesn't have to do with the T-cell count. It has to do with being PPDs above 5 millimeters. 5 millimeters is the cutoff for HIV. 5 millimeters is the cutoff for people who are on steroids. Who else is 5 millimeters the cutoff? Steroids, HIV, and children. Well, check with the pediatricians for children. Children might not need, listen, children might not have to have any reactivity. Elderly, no. Immunosuppressed, no. HIV and steroid use, yes. Leukemia, lymphoma, diabetes, no. That's 10 millimeters. 5 millimeters is HIV. 5 millimeters is steroid use. 5 millimeters is close contacts. Close contacts. Are you close contacts of each other? No, just friends. Are you in this room? It's a horrible thought, isn't it? You don't like the idea of this, do you? Them? What do you think? Are you close contacts? When did the course start? A week ago? Friday? Saturday? Last Friday? So we're at 5 or 6 days. We're 6 days of breathing 9 hours a day of air together. Hey, just about at close contacts. Don't say household contacts. Who are you having more contact with? Your family or me? Household contacts. When is the last time you saw them? You haven't seen them. Okay, so the answer is, by the end of this course, you would constitute close contacts of each other. Hours and hours a day of breathing the same air, yes, you would be close contacts. Are you considered close contacts of your patients? Absolutely not. Absolutely not. How much time do you have with contact with your patients? Come on. Surgery, you're not talking to them at all. Psychiatry, you're pretending to talk to them as you write out the Zoloft, the Paxil, and the anesthesia, you're not talking to them and all their breathing is going through a tube. And in medicine, you're having a hot love affair with the doorway instead of actually going into the room. You go into the room like this. Hi, how are you? Everything okay? How's that chest pain? Any more chest pain? Okay, we'll order some tests. See you later. Okay, so who's actually seeing anybody? And in pathology, they're not breathing. And you only see them in parts. I'm a close contact. I spend hours near my patients. At least a little section of his liver I did. So the thing is, you are not close contacts of your patients. You need hours and hours of contact for 1 or 2 weeks to be considered close contact. PPD of 5 millimeters. HIV, close contact, steroid use, organ transplantation. What else does this woman need in terms of prophylaxis? Toxoprophylaxis is Bactrim. So you don't have to be on it. You're already on it. Huh? Isoniazid is the PPD. Isoniazid for how long? 9 months. Used to be 12 months. Now it's 9 months for everybody. HIV negative 9 months. HIV positive 9 months. Been changed for 9 months for everybody. 9 months for everybody. Hepatitis B, yeah, if they put that there, you would say hepatitis B. Hepatitis B surface antigen, yeah, I go for that. Hepatitis B. Hepatitis B. Hepatitis B surface antigen, yeah, I can go for that. Yeah, all right. All right. Oh, yeah. What about fungal prophylaxis, yes or no? No. Not routine prophylaxis. No. Not fungal prophylaxis, not routine prophylaxis. Not necessary, not necessary. Okay? Not necessary. CMV, that will be the wrong answer. Fungal and fluconazole, that will be the wrong answer. Has to be something in the wrong answer. Those will be the wrong ones. PCP, MAC, that's it. What else does she need? She needs The HIV meds. HIV meds. HIV medications. When to start is easy. Because when to start is a recommendation. When to start is, we tell you this is the criteria, and that's when you start. When to start is easy. What to start is harder. When to start, well, T cells are good. When the T cells go low, you start the HIV meds. Virus is bad. When the virus goes up, you start HIV meds. The question is, how low is low and how high is high? T cells, how low is low to start the HIV meds? Huh? Used to be 500, now it's 350. Or a viral load greater than 55,000. Either of those. When the T cells go low or the virus goes high. Virus is bad. When the virus goes high, start the HIV meds. T cells are good. When the T cells go low, start the HIV meds and bring them back up. Virus is bad. T cells are good. When to start is straightforward. What to start is a little more complex. Okay? Lo, in the beginning, the world was without form and void. And then there was AZT. And AZT, which is more politically correctly called Zidavudine. And I was sitting around in medical school, people waking up 4, 5, 6 times a day, taking 2 or 4 AZT tablets 6 times a day, 24 hours a day, 12 midnight, 4 a.m., 8 a.m., 12 noon, 6 times a day, 2 to 4 tablets 6 times a day, and everybody died. But you died with what is the most common side effect of AZT? Not liver. Which bone marrow? Reds, whites, or platelets? No, mostly reds. There's not much effect on platelets and not as much effect on whites. It's mostly a cause of macrocytic anemia. Macrocytic anemia. Macrocytic anemia big time, big time, big time. And everybody died. So then by the time I become a medical resident, now we have DDI, DDC, D4T, I love you, you love me, didanosine, and stavudine. And people are waking up 4 or 6 times a day to take 2 medications. And they're very diligently taking 2 medications 24 hours a day, all day long. And the end result is, after taking 2 medications a day, 24 hours a day, the end result is you die. But you die with what is the major adverse effect of the D drugs? The D drugs. Pancreas and neuropathy. You end up dying with pancreatitis and neuropathy. Pancreatitis and neuropathy. You end up dying with pancreatitis and neuropathy. And that's the major side effect of the D drugs, pancreatitis and neuropathy. This is not good. This is not turning out so good so far. But all the D drugs have the same side effects. Well, we get to be around 1995, and some good news happens. We get 3TC. And people go, oh, that's good news? They go, yeah. And they say, well, that's lamivudine. And they say, what's the good news? Well, we got 2 bits of good news. 2 pieces of good news? Yes, it's now 1995, and we have lamivudine, Epivir. They have 2 pieces of good news. What's the good news? The good news is this drug has no side effects. That is good news. What's the other piece of good news? Lamivudine gets rid of another disease in your body. Hepatitis B. It makes your hepatitis B go away. Your hepatitis B E antigen. It makes your hepatitis B E antigen go away. It inhibits the growth of the hepatitis B virus. And people go, no side effects? Yeah. Gets rid of your hepatitis B? Yes. Well, that is good news. What's the bad news? You're still going to die anyway. Oh. Well, that's not ideal. Now, before you commit suicide around the nature of the drugs, you go, oh, look, Vudine. 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 Osine. Vudine, Vudine, Vudinosine. Vudine, Vudine, Vudinosine. Vudinosin, yes. And you die anyway. So, that's bad. Now, we got some, okay, so these nucleosides, these reverse transcriptase inhibitors, by themselves won't get rid of anybody's HIV. However, protease inhibitors are different. Because when you combine two nucleoside reverse transcriptase inhibitors and one protease inhibitor, then you get a different thing. When you combine two nucleosides and a protease inhibitor together, you go to undetectable levels of viral load in 80 to 90% of patients. Combinations of two of those nucleosides plus one protease inhibitor results in an undetectable viral load in 80 to 90% of patients. That's very different. That's very different. Now a guy sits around and goes, well, that's good news, but what should we call them? How about Pril? No. Alol? No, that's taken. Fluoxetine? That's taken. Statin? Sartan. Mycin? No. Well, what do we use them for? Well, we use them for a virus. So what should we call them? Oh, Avir. We use them for a virus. Avir. Nelfin. Avir. Saquin. Avir. Raton. Avir. Empren. Avir. I love you, my dear Indian. Avir. Raton Avir. Relfin Avir. Saquin Avir. Raton Avir. Whatever Avir. Oh, yeah. The good news is that when you combine two nucleosides and a protease inhibitor, you go to undetectable levels of viral load in 80 to 90% of patients, and it stays there, and it doesn't come back. Now, what's good about going to an undetectable viral load? What happens to you that the patient's like? You don't die. The nifty thing about an undetectable viral load is you can't die. You don't die. You cannot die with an undetectable viral load. So if you go undetectable, you don't die. And there's usually, in a group like this, somebody will come up and go, I have a question. Yes. You said you can't die with an undetectable viral load? Yes. Well, you could still be shot, couldn't you? I mean, you could still get, run over by a bus or something, right? I mean, you could still die of some other reason, right? At this point, they usually go, no. You can't die for any reason. You become immortal. Permanently. Go ahead, shoot me! I'm undetectable. My viral load is undetectable. Bing, 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 bing. Can stop a bullet. Bless you, my child. So the thing is, you don't die of your HIV. Once you get the HIV to undetectable, how long do you have to continue these medications? Forever? Well, not forever. Not Mr. Cheerful over there until you die. Just until the HIV is cured. So you continue them forever or until the HIV is cured. But the good news is if you stay undetectable, you won't die of HIV. Now, as a group, what is the side effect of protease inhibitors as a group? Not bone marrow. They're metabolic side effects. They have rather significant...
Lactic acidosis.
Lactic acidosis is with the ones on the left-hand side, the reverse transcriptase inhibitors. Lipodystrophy, which means what? Lipodystrophy.
Accumulation of adipose tissue in some form.
You start becoming like Cushing's disease. You can start getting this thing that looks like Cushing's. You can get stria, truncal obesity, wasting of your arms and legs. You start humping. You get a humping, stria, truncal obesity. Hyperlipidemia and hyperglycemia. Increased glucose, increased lipids. Increased glucose and increased lipids. Increased glucose and increased lipids. Hyperglycemia and hyperlipidemia. Between those two things are protease inhibitors. Okay? Now, boards love side effects because they don't change. You see, 15 years ago, AZT was the standard of care because it was the only approved drugs. 10 years ago, AZT and DDI, or AZT and Stavudine, were the standard of care because there were no other drugs. 7 years ago, 2 of these and 1 of these protease inhibitors became the standard of care. So in the last 15 years, the standard of care has changed 3 or 4 times. But the most common adverse effect of AZT has always been anemia. So any time in the last 15 years, as these other drugs came out, side effects don't change. That's why they're good on the boards, because the questions may change. The standard when you start. 2 years ago, I would have been saying T cells less than 500 or viral load above 20,000. Now I say when the T cells are less than 350 or viral load above 55,000. Which of these drugs causes kidney stones? Indinavir. The only one here that causes kidney stones is indinavir. Kidney stones. Indinavir. Okay. Now, 29-year-old male surgical resident gets stuck on a HIV positive needle in the operating room. The surgeon sews his finger into the sternum. He's closing. Sews your finger into the sternum. What do you do when you get stuck on an HIV positive needle? What do you do? AZT is the most common wrong answer. I'm sorry. Isvinitya. Combination. What does that mean? Arroz con pollo? What do you mean by a combination? Soup and a sandwich? A month worth of 2 nucleosides and a protease inhibitor. A month's worth of 2 nucleosides and a protease inhibitor. Not AZT alone for anything. Not AZT alone. A 27-year-old male surgical intern goes out to Hollywood tonight and has unlimited, unprotected sex with 385 people in Hollywood tonight. Comes to see you tomorrow morning in class. What do you do for him? 2 nucleosides and a protease inhibitor for a month. Splashed in the eyes with blood. 2 nucleosides and a protease inhibitor for a month. The condom broke with my HIV positive partner. 2 nucleosides and a protease inhibitor for a month. Whatever you get stuck on, if it's HIV positive, 2 nucleosides and a protease inhibitor for a month. Questions on this? Pregnant lady. No, 27-year-old woman who's HIV positive and has a T cell count of 30 and a viral load of 285,000, and she's 7 weeks pregnant. And she says, my baby's brain is being formed this afternoon. What do you do for her? Huh? AZT now or AZT in the second trimester? AZT now is incorrect. AZT now is incorrect. Who says AZT in the second trimester? AZT in the second trimester? Is never right in this case. Tell her to get an abortion. When do you do that? Never. Never. Wrong go. Wrong, wrong, wrong. Wrong, wrong, wrong. Two plus one in the second trimester? Or now? Is the answer. Look at that T cell count. Very low. Look at that viral load. Very high. You can't withhold the drugs from her. If you withhold the HIV medications from her, she'll be dead before the baby is born. Death of the mother is an adverse pediatric outcome. The worst birth defect is death of the mother. All right? So you don't punish her because she's pregnant. Oh, sacred bearer of the race, get your rosaries out of my ovaries, that type of thing. Yes? You should get an HIV test, but I won't tell you when you have to get it. All I'll tell you is that if you get stuck on, not you, of course, but should you get pricked with, all I'll tell you is that at 6 weeks, you have about 70 or 80% conversion. At 12 weeks, you have about 95%. And at 24 weeks, which is 6 months, you have 99% sensitivity of the test. So anything time you get stuck, you should get a baseline test and a follow-up test later on. Neonate born to an HIV-positive mother, the baby gets AZT for 6 weeks. This person gets 2 nucleosides and a protease inhibitor for how long? For life or until the HIV is cured. Whichever comes first. Would you give her Bactrim? Yeah. 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 Now, what's the major... in pregnancy, Bactrim has a relative contraindication. What's the relative contraindication of Bactrim in pregnancy? No, jaundice, kernicterus. When? At the end. Watch at the end. 8-trimethoprim sulfa. Bactrim can give kernicterus in the last 2 weeks. Look, 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 look. 37 weeks pregnant. Would you give her the Bactrim? Yes. Yes. The priority is to keep the mother alive. When you keep the mother alive, the baby will do better. Your priorities, man. You got to get your priorities straight. Keep the mother alive, the baby will do better. Look up, look up. Look up, look. T cell count, 530. Look up, look up. Viral load, 5,000. What do you do for her? AZT in the second trimester. If the woman doesn't need the drugs for herself, you give her AZT in the second trimester. If the woman does not need the medications for herself, you give them AZT in the second trimester. If they don't need the drugs for themselves, AZT in the second trimester. Clear? 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 No, in the second trimester through the pregnancy, the second and third trimester. Questions on that or this?
How about saliva?
How about saliva? Saliva, how about it? Can you get HIV from kissing? Can you get HIV from kissing? Huh? I mean, taken generically, not you said French, Russian, creamy Italian, okay, Madras, whatever. If you bite. That's true. Actually, it's not the biting. It's the breaking the skin and swallowing is the problem. So the thing is, no, there's no HIV transmission with kissing. Okay? So kiss up on the next break, okay? Okay? Make it like a 13-year-old's house party, all right? So we're going to have a big make-out party this afternoon because there's no transmission from kissing. It's a new romance. Unlimited kissing and none of that other stuff.
Will you be discussing the ethics and the current legal
If you're specific about what I'm talking about. What about it? To be specific, what do you mean?
Well, what are the rules?
I've got to be more specific. I can't. It's too generalized the question.
The baby, when the baby born,
Be more specific and then come back again with it. Huh?
the baby born to an HIV,
Baby born to an HIV-positive mother.
we give
AZT for 6 weeks because with the 2 nucleosides and a protease inhibitor, 98% of children are going to be born HIV negative. Now, I'm not sure what you mean with the ethics stuff. That's why it's too broad a search. I will give you 2 circumstances. One, how about this? A patient walks into your room and says, you tell him, listen, your HIV test is positive. And he's a 40-year-old guy and his girlfriend is in the hallway. And you say, did you tell your girlfriend that you're HIV positive? And he goes, no, I'm not going to tell her. She'll kill me. Are you sexually active? No, she just lies there. But the point is, your girlfriend's out in the hallway. The girlfriend, not you. Sorry. The girlfriend is out in the hallway and says, did you tell your girlfriend that you're HIV positive? No way, man. She'll get rid of me. Do you have the right to inform the girlfriend?
Yes.
Yes. Are you legally protected if you go and say, honey, come on in here? What? And you tell her that she's been exposed. Yes, you're legally protected. You're legally protected. If you do partner notification. There's always been protected for partner notification. Okay, so you are always legally protected. It's like, what do they do in psychiatry? The Tarasoff laws. You know, hi, this doctor-patient relationship, and I'm a schizophrenic, and I'm going to kill my boss today. And you go, well, why didn't you tell the guy? Well, because doctor-patient confidentiality. So what happened? It killed him. Oh, I didn't want to break the confidentiality. So you have the right to inform the partner. But if you have to be more specific about any other types of ethical issues, I think partner notification is probably a pretty good question. You always have to have written informed consent to do HIV testing. But if you'd be more specific, I can be more specific with you. There is legal protection to inform, but there's not a legal requirement, interestingly enough. It is not a legal requirement. In other words, if you don't inform, you are not prosecuted. I don't know why, but you're not. You get stuck and the patient does not want the HIV test. The patient has the right to refuse. You can't test them against their will. Okay, patient gets stuck on a patient, you say, are you HIV positive? I ain't telling. Have you want to know to get a test? I'm not going to do it. You can't test them against their will. There's a sneaky guy. There you go. Sound like my dentist. He says the patient is in the room and they're knocked out under anesthesia, and they're not awake to refuse. Like certain dentists that I know. Okay, well, they're not awake to refuse. Weren't awake to refuse, so you didn't say no. No, you can't go testing them. You can't just put people out under anesthesia and say, well, they were unconscious. What can you do? That's good, sneaky boy. A pregnant lady with accidental exposure to HIV. That's a very tough question. I'd give two plus 1 for a month to the mother. Which of those drugs is teratogenic? None of them. None of them has ever been shown to be teratogenic. Follow-up for needle stick. There's about 80% conversion at 6 weeks, about 90% at 12 weeks, and 99% at 24 weeks. When do you do the test? I can't tell you that. You notice that's not, I won't tell you that. Let's put it this way. See, this is a good example why I can't tell you. You're waiting for results of step 3. How often do you check the mailbox? Female, vaginal. Female to male transmission is about 1 in every 3,000 exposures, events, episodes, miniseries, whatever you call it. Male to female is 2 or 3 times more, about 1 in every 1,000 events, episodes. That's without treatment. Without treatment, needle stick is 0.3%, about 1 in every 300. Anal receptive is about 1 in every 100 shots, loads, whatever you want to call it. Unprotected, vaginal transmission. Hands here. Why is it that male to female transmission is so much more than female to male? Hands. Who? What's that?
More for the female. So much trauma for female. More than.
Trauma for the female?
Yeah. Yeah, that's true.
Brother, you have got to slow down. Okay? Make an investment. It'll pay off, okay? Okay, there's a person under there. Okay? Okay? Excuse me. Thank you. Trauma for the female. By the way, welcome to the most common wrong answer. Well, woman's subject to a lot of trauma. Rips, abrasions. Hey. Take time. It's like a flower, you know? No? Hands? Why?
Because the number of the virus is high in the semen.
Number of the virus is high in the semen? That's partly true? That's partly true? Warmer?
I think that's high.
What? Stays longer? Or surface area? Who says surface area? Surface area? The surface area of the man has been much smaller? Well, you know, it's not the surface area issue. But what units are you using for that? Is that centimeters squared? So it's not surface area. That's the second most common wrong answer. But anyway, you never can tell who's going to say it. You know what I mean? Well, you know, the surface area of the man is just much, much smaller. That's why they like to look at themselves in rear view mirrors, you know? Warning, objects may appear larger than they... Okay, that's not it. The reason for the transmission from male to female being much greater is duration. The virus is in higher concentration of semen because of white cells, but it's duration of contact. The woman is exposed to fluid in the vaginal vault for 4 or 5 hours of exposure in the vaginal vault. That's why you can't take out your diaphragm right away. You've got to leave that diaphragm in there. So the woman's exposed for hours, 4 or 5 hours, to semen in the infected in the vaginal vault, whereas the man's only exposed for about who said seconds? Are you dating him? I told you. Tell him to slow down. Make an investment. It will pay off. Okay? Seconds. Well, it's not seconds, but it is less than 4 or 5 hours. Now, anal receptive. Now, this is a tough one for people because down in Miami, the Cuban guys go like this. Now, what do you mean by anal receptive? No, I can't. Well, everybody is receiving something. No. I mean, everybody is getting a little something. No. What do you mean? Being on the receiving end of semen. Being on the receiving end of semen. Okay? Being on the receiving end of semen is the issue. And rectal mucosa actively picks up those infected white cells and transmits much more often. Questions of this? Yeah.
Can you, as a patient, request your surgical team or the person who's going through a surgical procedure on their status to HIV?
Request the HIV status of the surgical team. They can request it, but they have no legal right to it. They can request anything. They can request your mother's maiden name. But the point is, people don't have the right. You don't have the right. Patients don't have a right to know what your HIV status is.
HIV patient generally very thin. Are you seeing that the 2+1 change diabetes?
What'd she say?
I said the HIV patient generally very thin. But
Virus.
Virus thin. Like thin.
Thin? Thin virus?
No. HIV patient because they become weak.
Oh, they do become weak, yes.
But the 2+1 changing that image
Yes, they do become Cushing's, and they gain weight. Yeah, big. Definitely, you gain weight. Actually, people with all these medications, if you shut off the virus, people will gain weight and will gain lots of fat, and that's true. You gain weight, yeah. What about the person giving it to the other person? What are you talking about? What about the person giving it to the other person? What do you mean? Here we go. He's talking him. Is there any risk for the inserter? It's the same. I don't want to cause a seizure because he looks like he's about to like, what about the, oh my God, I'm asking a question about anal sex in front of 100 people. I can't believe it. It's normally 200. Okay. So the answer is there is a risk, but it's much less. It's much less. Being on the receiving end of semen is always worse. Can lesbians get, funny you should be showing up here. Rahul, can lesbians transmit HIV to each other? There we go. We get the engineering guy who's going to answer. Prove this. This will prove it to us. Can we get the engineering guy to pass USMLE Step 3? Okay. Clay? Hi, thanks for stopping by. Clay?
Very welcome.
Clay, okay. We're discussing HIV transmission. Tell us, Clay, is it possible for lesbians to transmit HIV?
Can they transmit mucus between each other?
Can they transmit mucus? No, they don't like it.
Absolutely.
Absolutely. There it is. That's it. It's just much less. It's just much less. Okay? Now, that's down in Texas. There's usually 40 minutes of lesbian questions. Okay? But it's just much, much less. Okay? All right? Any other questions on the HIV thing? Loud and fast. When you don't know the status of the other person, I can't give you an answer. That's a good question about not knowing the status of the other person, and you get stuck on something from the other person, you don't know the status. I can't answer that because it depends on the nature of the other person. I get this call all the time. I got stuck on a needle. Oh my God, I got stuck on a needle. Oh my God, I'm going to die. Who'd you get stuck on? A 98-year-old Russian lady in a nursing home. It's like, oh, relax. You probably caused more disease going into her than you out of her into you. Did you have your blood on that? You're probably damaged her. I've been giving her the 2+1. Oh, I got stuck on a 32-year-old prostitute who's HIV unknown. I can't tell. So I can't tell you. HIV unknown depends on the circumstances. Yes. You can't test people without consent. You can't test people without consent. That's autonomy. It's autonomy. You can't test people without consent. Can't do that. Back to the anal insertive question. Quiet. Shh. No, quiet. What? They tested? No, there's no requirement for testing in residencies. There's only one group of people that are required to be tested, and that is the armed forces. If you don't want to be tested, you are shipped out. And only in the armed forces. But even then, you have to give consent. It's kind of like inspection at the airport. You can refuse the inspection of your luggage, but you're not getting on the plane. Okay? So it's the same thing with you have to give consent. You can't be tested against your will. And residents definitely are not tested.
Breastfeeding for the HIV.
Why? Did somebody tell you that? Somebody told me, oh, wait a second. They told me I had to be tested. No. What?
Breastfeeding for the HIV positive mom.
No breastfeeding for HIV positive mothers. Ever. No breastfeeding. What? You have to be mindful. We're filming and think. I'll take the questions. We have the time, but you can get CD4 counts without consent. You don't need consent for a CD4 count. Okay. Well, so that those of you who are worrying about lunch, all I'll tell you is that I will see you at 2:10. 2:10. So the people who are worried about having a part of their lunch biopsied. Okay, I'm refunding your lunchtime back to you. Don't worry, we're in good shape. We have another hour or two of infectious diseases, and then we're going to go on to emergency medicine later on this afternoon.